The video is about progressively optimized fixation method for Levonorgestrel-Releasing intrauterine device. LNG-IUD effectively treats adenomyosis, relieving dysmenorrhea, reducing menstrual flow, and easing symptoms. But Mirena faces high expulsion in adenomyosis patients with enlarged wide uteri, reported rates of 25%, even 37.5%. With GnRHA, displacement expulsion still range from approximately 13% to 17%. Reducing LNG-IUD expulsion in adenomyosis matters even with oral or injectable alternatives, as LNG-IUD offers unique long-term benefits these drugs can't match. Over a decade ago, we explored reducing Mirena expulsion in adenomyosis patients. Before widespread hysteroscopy, we used concurrent Mirena and copper IUD insertion for mechanical stabilization. This reduced expulsion somewhat, but displacement or expulsion remained common. Domestic literature has only one small 40-patient study, with 10% expulsion at 6 months, limited clinically due to short follow-up and lack of focus on uterine cavity depth. Inspired by Fix-IUD's fixation system, we bound the two devices and secured them to the uterine fundus. But patients reported significant vaginal bleeding and lower abdominal pain, requesting removal. We abandoned this method after 5 attempts. In the past 3 years, we have established a diagnosis and treatment center where we can conveniently perform hysteroscopic surgeries and fixation for adenomyosis patients with dysmenorrhea or menorrhagia, especially those with a prior IUD expulsion history. Knot A is a dead knot, designed to prevent the Mirena and thread from detaching. Knot B is embedded in the uterine myometrium and requires the non-absorbable proline suture to form a thick knot. This initially fixation method also has been widely applied in China. You et al. Reported 31 cases of hysteroscopic fixation using this method, with no expulsion during the 6-month follow-up. That said, an incident occurred one day. A patient had her IUD removed by a doctor unaware of her Mirena being fixed. Without anesthesia, the doctor forcefully tried multiple times over 30 minutes. Though removed, she experienced persistent pain and cried outside the clinic. However, 1 year after another patient had the Mirena fixed, she developed severe depression due to unbearable spotting and insisted strongly on its removal. We performed the removal under hysteroscopy. During the procedure, we observed that the knots could only be extracted after multiple separations and tugs, which confirmed that IUD removal was indeed challenging and also indicated that the fixation method was highly secure. Thus, the initial method had 3 disadvantages. Knot A, a dead knot, difficult to remove the IUD. Knot B, small knot, easy to fall off early, and extra costs. So we optimized these 3 aspects. Take a typical patient as an example. A 43-year-old G4P2 patient came to our hospital with the chief complaint of 10-year history of recurrent heavy menstrual bleeding, failed Mirena retention twice. 2 years ago, her Mirena expulsion occurred 6 months after insertion. 1 year ago, sequential expulsion of co-inserted copper IUD and Mirena occurred at 5 months post-procedure. Figure A, B, and C showed pre-treatment ultrasound measurements of uterine dimensions, 91 by 82 by 81 millimeters. D showed sonographic evaluation after 3-course GnRHA therapy, and uterine dimensions is 74 by 60 by 70 millimeters. Then she was recommended to our hospital to receive the hysteroscopy fixation of Mirena. Knot A, a sliding knot. The routing method of its new suture is shown in the figure. Using the mesh openings of the surgical instruments basket, a single operator can complete the procedure independently. The optimal measurable distance is approximately that of a cotton swab. If too loose, the ring may easily slip out of the loop during placement, whereas if too tight, removal becomes difficult. At least 3 knots are required for fixing knot A. The distance between knot A and knot B is approximately 1.5 centimeters. Knot B, generally, at least 20 knots are needed. Finally, secure the noose with additional knots, at least 3, to form a properly sized loop knot. Then put the modified Mirena back into the delivery system for insertion into the uterine cavity. We are using an integrated continuous flow hysteroscope, Wolf 8986.401, with a 5 FR working channel, through which micro-scissors and microforceps, blade length 8 mm, can be inserted for operations. The Mirena was inserted into the uterine cavity by Mirena delivery system. The micro tip of micro-scissors was used to poke a gap of approximately 1 to 2 millimeters in the center of the fundus, with a depth of 8 millimeters. The loop knot was slowly rotate and embed into the gap with microforceps. After confirming that the knot would not fall off and was in the right position in the uterine cavity, the hysteroscope was withdrew. Result: one gynecologist performed Mirena fixation independently within 5 minutes. The patient was discharged home after 30-minute recovery room monitoring. Ultrasound showed normal IUD position and a 1 by 0.5 centimeters hyperechoic area at the uterine fundus. To date, we lack relevant IUD removal videos and thus did simulated operations. The video depicted removal as simple, no thread removal, and a new Mirena can be reinserted. For expulsion concern, clamp both arms with microforceps and place it in the original not a loop under hysteroscope. If unmanageable, use a slip knot to secure its arms, then after placing it into the loop, loosen the knot. Thus, we have made 3 optimizations. 1. Knot A was modified into a slip knot, facilitating removal and reinsertion. 2. Knot B was redesigned into a loop knot. When placed in a narrow space, it automatically expands to fill the area, providing some support and further reducing expulsion risk. 3. No additional medical consumables were required. The fixation thread was replaced with Mirena's pre-attached tail thread component, polyethylene, which is biocompatible. In 2021, Tong et al. First reported suture fixation of LNG-IUD via hysteroscopic cold knife in an adenomyosis patient, summarizing their 2-year experience with this approach. Our team also performed 212 hysteroscopic Mirena fixations, May 2022 to July 2024, with 5 loss to follow-up, 3 expulsions, 3 hysterectomies, and 5 self-removals. Of these, 159 had uterine depth greater than or equal to 9 centimeters and 45 had expulsion history. Our surgical method, by contrast, offers 10 advantages, including learning curve, instrument consumable needs, preoperative cervical preparation, delivery method, removal difficulty, operative time, intraoperative bleeding, physician requirements, and expulsion rate. Our method also has a limitation: no follow-up data on fertility post-fixed IUD removal. Notably, hysteroscopy is need to remove the fixation knot when the patient wishes to conceive, as the remaining suture in the uterine cavity may interfere with embryo implantation. After removal, the uterine cavity has no scarring but a superficial tract, depth less than 8 millimeters, seemingly without effect on embryo implantation. In conclusion, our optimized fixation method for LNG-IUD is simplicity, ease of mastery, low instrument needs, ultra-low expulsion rate, as well as high universality.